Alright, look, the mass is going into the pterygopalatine fossa. Alright, so you see the pterygoid wedge here. So this pterygoid wedge has been replaced by the mass. So this is going inside the pterygopalatine fossa, eroding the wedge, and it is also eroding the floor of the sphenoid sinus. Alright. So similarly, if we see the axial cuts, you can see, if we come and from inferior to superior, you can see from the floor how it is eroding the medial wall, how it is eroding, and it is completely eroding there, completely eroding there, eroding there, eroding there. See how it is going again towards the orbital apex and the posterior ethmoids. Okay, so to me it may not be AFRS.
So are you thinking it to be an inverted?
Yes, it can be inverted papilloma. It can be inverted papilloma. Alright, so if it is an inverted papilloma, we'll do, maybe we'll do the modified Denkers if required, but we'll remove each and every bit and we'll try to find out the attachment and we'll try to drill the attachment. Now, one of the very characteristic of inverted papilloma is you get a bony spicule. Now, you come to these pics, these cuts here. So, you get a bony spicule, sharp rectangular piece of bone, and that is most likely the origin of the inverted papilloma. But in these cuts, I cannot see very clearly any bony spicules which can give rise to inverted papilloma. But in these one of these cuts, so like here, this one. So along the floor, this can be one of the spicules that along the floor that it may be arising. I am not very sure about it.
Okay.
All right.
Okay.
So now, so this is all about the pathology. Now we have time since the patient is not shifted yet, so we can go ahead with the CT-PNS, like how to read the CT-PNS.
Yes, please.
All right. So you cover these two lines. Okay. So in this CT we have, these bony windows. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 coronal images. All right. So generally, so these 10 coronal images are more than 5 mm, right? So distance. So I would like to have a 0.5 or 0.6 mm of cuts for the better viewing. Whatever information we get. So this is the first cut. In this cut, you can see this frontal bone above. This is the frontal bone above. You can see the nasal bones. You can see the nasal septum that is deviated on the right side. You can see the left inferior turbinate, and you can appreciate little the right inferior turbinate also. All right, the second cut, we come across both the maxillary sinuses. You can see the right one is diseased, left one is there, and there is a opacity in the right maxillary, right frontal sinus also. All right, and we can see the orbits also now. Now, if you look at the floor here on the right side, left side, all right, so this structure, this is not a cell, not a disease, but this is what? This is infraorbital nerve. All right, so we saw the yesterday that the infraorbital nerve runs in the floor of the orbit and runs posteriorly, then goes into the pterygopalatine fossa, and then it runs into the foramen rotundum along the floor of the cavernous sinus. So this is your infraorbital nerve. So again, this is your infraorbital nerve on the left side. This is your infraorbital nerve on the right side. See this. All right. Can you see this structure? Yes, yes. That's the infraorbital nerve on the right side. Now this part, this you see the frontal sinuses above and this thick bone below. All right. So this is frontal beak.
Rajiv, regarding that frontal sinus, how would you differentiate between a mass and retention of secretion because of blob frontal loss?
So actually we cannot distinguish it on CT. Either we can distinguish it on a contrast. If there is a mass, it may enhance on contrast, and if it is or simple secretions, it will not enhance. Second is MRI. MRI is the best the modality which can tell us whether these are secretions, this is a mass, this is fungus. So that will tell us more details so far as the soft tissue is concerned. CT will give us all the bony details, right? The CT scan is good for the bone and MRI is good for the soft tissues. Now when we come to this third cut, in the third cut, see, this bone is gone, right? So we are right at the frontal recess here, and you can see this, the right frontal recess is also involved and it is quite narrow. And you see, and this is anterior cranial fossa, all right? So this is frontal and this is anterior cranial fossa, not to be confused. This is frontal recess. Okay, so then we come into. So this one, so this may be some mucosal hypertrophy inferior to the infraorbital nerve, all right, or an isolated polyp, simple thing. Now in this picture, one more very important thing that you can see on the left side, you can see on the right side, but it is difficult to make on the right side, but you can very clearly see this. Can you see this structure on the left side? This is nasolacrimal duct system. All right, see how it opens in the inferior meatus. So this is NLD. Now we coming to this cut. So now here, so someone asked about the supraorbital cell yesterday. All right, so you see there is no frontal sinus above now. This is all anterior cranial fossa and this is cribriform plate. Okay, you see this is crista galli, this is cribriform plate, medial lamella and the lateral lamella of the cribriform plate. So any pneumatization that extends supraorbital, that is posterior to the frontal sinus, is supraorbital cell. It's as simple as that. So this pneumatization going, this is little small supraorbital pneumatization. It is a part of anterior ethmoid pneumatization only. And now you can see these cells. You can see this cell, this cell. Can you make out this small bony cell? If that's bulla, all right. So that's bulla, and on the left side you can see maybe this one is bulla. So on the left side. So and I cannot really see any agar nasal on the left, but to me this can be the agar nasal on the left side.
Yes, the cut is quite.
Yeah, so this is on the right side. So it's not very clear where is your uncinate process because of the cut, sir. But the uncinate process will also be somewhere just 1 millimeter maybe posterior to this cut. Okay, so then we come on this picture. Now, so to me that is the area of the ground lamella. Okay, so you can see on the left side there is some structure that is attaching to the lamina papyracea, right? So that can be the ground lamella, all right. So from this cut posteriorly you may have posterior ethmoid air cells, all right. And one more very important thing in this cut, all right, you see the orbit on the right side and on the left side. That is your, not very clear, but that is your medial rectus muscle on both the sides. That is your medial rectus muscle, and this one is your superior oblique muscle. This one is superior oblique. So they are very closely related, right? And you see how this beak is forming here, all right, on both the sides. Can you see this one? So anterior ethmoidal artery comes out at this point between the medial rectus and the superior oblique muscle, and in this case it runs along the skull base. So in this case it is not in the mesentery, but it is running along the skull base. So we are not having a very prominent anterior ethmoidal artery in this case. So when it is covered with mucosa, it is not easy to identify this anterior ethmoidal artery when it is completely in the skull base. Okay, but yes, so this is the area. You see how thin the bone here is, right? You see it is almost looks like there is no bone here, all right. So this is the thinnest part of the skull base where we can go intracranially and cause any injury.
the floor of the pulpit is eroded on the right side.
On the right side, yes. So yes. So again, so very thin bone here. So a very thin bone here, you can see. So very thin bone here. So I don't know whether it is eroded or not, but let's see when we operate this case that how this is. But I cannot clearly say whether this is eroded or not. Now coming to this cut again. So now again you see this is inferior turbinate. You can see this is all the homogeneous opacity. So looks like a mass. This is again completely gone. Yes, absolutely. Even the palatine bone is ascending process is also gone. So now you see the transition between the anterior ethmoids. See the small cells. Can you see here the small cells and compare it with this cell? Right. So this is a larger and the bigger cell. Posterior ethmoids are larger and fewer. And now you see how posterior ethmoid cells are opening. Right. So one large cell. Right. One large cell. And you see this is the posterior most part of your middle turbinate. Right. Middle turbinate that is getting attached here. See. And now this structure is most likely your superior turbinate. This one. Can you see? This one is your superior turbinate. Now the posterior ethmoids lies lateral to superior turbinate. Superior turbinate forms the medial boundary of the posterior ethmoids. Okay, so this is your superior turbinate, these are your posterior ethmoids. You can see this small space between the superior turbinate and the nasal septum here. Alright, so this leads to your sphenoid sinus os. Alright, so between the superior turbinate and the nasal septum. Now till this point there is no sphenoid sinus. Alright, it is all posterior ethmoids. And also note the skull base. Skull base anteriorly. See the skull base anteriorly how slanting it is. Right, how it is divided into the medial and the lateral lamina. And see the skull base in the posterior ethmoids. It is thick, it is flat. Alright. So sometimes and rarely at this point, you may get a posterior ethmoidal artery. It is not very evident here, but we saw the posterior ethmoidal artery in our dissection yesterday. So you may see the posterior ethmoidal artery at this point. Now this is what are now sphenoid sinuses are coming. Now there are a lot of septa, a lot of partitions in the sphenoid sinus. All right. So when do we say that the sphenoid sinus has come? It is not the posterior ethmoids. So far as we are in the posterior ethmoids, we have a straight septum here from the skull base to the floor. All right. When we have when we are in the sphenoid, you will not have a straight septum. You will have a septum here, vomer bone, and this will not be in continuity with the sphenoid sinus. So when the septum is not in the continuity, it means we are in the sphenoid sinus. Now see, this is the posterior ethmoid cell. This posterior ethmoid cell is extending posteriorly here. See, and this is orbital apex. So this is the sphenoid sinus. All right. These are the partitions in the sphenoid sinus, and this is the extension of the posterior ethmoids into the posterior most part near the orbital apex. This is what? A noddy cell. This is how your noddy cell will look like. If we go like this here and we start our debrider, use our debrider here only without opening the sphenoid sinus, there are high chances that we will injure the optic nerve here. All right. So similarly, even on the right side, you are having a small noddy cell on the right side also. Okay. So what is this? This thing. Okay. This is orbital apex and this is superior orbital fissure. Okay. We saw the superior orbital fissure yesterday. So all the nerves are entering from the cavernous sinus into the orbital apex through this superior orbital fissure. Right. And this is the inferior orbital fissure. Right. And then we come into the sphenoid sinus here. Under kar do. Now we come to the sphenoid sinus here. You can see the partition in the sphenoid sinus. This is the right sphenoid sinus and left. Left sphenoid sinus is dominant. Remember, in 80% of the cases, the intersphenoidal septa will be asymmetrical. It will not divide the sphenoid sinus into two equal parts. It will be dividing into maybe right prominent and left more prominent. So never rely on this septa as a midline structure. All right, whenever you are doing intersphenoidal work. Now there are various anatomies, various structures yet that you can see in this single cut, right? See, this is the anterior clinoid process. Anterior clinoid process, okay? This is where your optic nerve lies. This is your optic nerve, all right? And see this bulge, right? Here are your carotids, and this depression. See this depression between the optic nerve and the carotid here. So this is your lateral opticocarotid recess. Okay? Then you have this structure, something going on through this foramen, that is V2. All right, so that is V2, and you can see something going along the floor also. This is Vidian. All right. Vidian is inferiomedial and V2 is superolateral. And you see this pneumatization going between the Vidian and the V2. Sometimes this may extend to this greater wing of the sphenoid also. That forms the lateral recess of the sphenoid. So many a times we can, if this is pneumatized and there is a disease here, we cannot approach from this side. We have to go transpterygoid. This is the pterygoid wedge here. All right. This is the medial pterygoid plate, lateral pterygoid plate. Okay. The same structures on the right side. Pterygoid wedge, medial pterygoid plate, lateral pterygoid plate, Vidian and maxillary. Okay. So, and you see here, that is what I was saying. See, the disease is involving the pterygopalatine fossa. It is eroding the see here and this area and compare it with this area. See the widening here, widening and erosion here. All right. So to me, it doesn't look like an AFRS. It is something else. Let's see what it comes out. It can be inverted papilloma, can be some hemangiopericytoma or something else. Patient do have a history of nasal bleed also. So let's see how it comes out. Okay, so these are the coronal cuts. So any questions or anything related to the CT?
You have given a very detailed explanation of all the findings there. Thank you so much. And if there is any questions?
Sir, how would you explain this heterogeneity?
This can happen in in like in hemangiopericytomas also. These heterogeneicities. This can happen in inverted papillomas also. So ideally, this CT should be contrast enhanced at least, or along with an MRI for having a detailed investigation. And we know that. This is the third recurrence of the patient. This is the third revision case. All right. So so this is the best chance. We cannot say the patient will have again a fourth surgery. So to me, this, because of this, the nature of the disease, maybe everyone expected AFRS. This was an half-heartedly done surgeries 2 times there. So we'll see. If required, we will do Dankers. If we see we cannot reach the anterior most part of the disease, we'll go for with the Danker. Otherwise, what the advantage here is, the advantage to me here is that I don't have a inferior whole of the medial wall of the maxilla is gone except anteriorly. If needed, I'll just remove this bone. I need to remove this bone. I'll remove inferior turbinate. I'll remove this part of the bone, and whole of the maxillary sinus will be in front of me.
Dankers would be an ideal thing for this, because the thing is, by doing Dankers, you will reach to nooks and corners of the.
Yes, we'll do Dankers. That is not a big
and
issue.
The second thing, the follow-up is easy. follow-up endoscopies are too good if you
Okay,
have
so
dentals.
actually we have one issue here. So we have a straight blade only. We don't have a curved divider blade, 40 rad or 60 rad. So everything what we have to do is we have to do with a 0-degree divider blade.
Use the angled forceps with a cotton ball or gauze and they'll scrape the disease off the bone.
Your own search technique.
Right. No.
ক্যামেরাটা এখন এখানে লাগাই ভাই
You have pneumomycosis here? How many cases?
সেকেন্ড কেসে তোমার নাম লেখা
सिस्टर वॉश हो रहे हैं? हाँ वॉश हो गए. अच्छा एक जना और मुझे वॉश चाहिए सो डैट इरिगेट करने के लिए. हाँ वॉश हो जाओ. राइट.
100 patients. You know, like 496 का तो मेरे पास डेटा है. म्यूकर इतना आया होगा. इधर डायबिटिक लोग कम है. इधर डायबिटिक लोग कम है.
ओके ओके राइट ठीक है कर दो पैक कर दो.
Yes, and COVID भी कम था. नहीं था. अच्छा. हम लोगों का केस आया. हमारे स्टूडेंट्स सब modified dankers, सब endoscopic surgery, orbital examination.
या स्टॉप इट.
আপনি ডাকছে স্যার
স্যার গেছে দেবলে না বাদ দত্তা
বিপ্লব স্যার
हेलो यस.
We have a 40 rads and 60 rad divider blade. Mr. Liberty is there from Striker. He will provide you. Don't worry.
ओके ओके सर थैंक यू सो मच. राइट ओके.
অফ করে দাও স্যার
हाँ
নামো
रुक जाओ.
Meanwhile, the breakfast of the second day is ready. All the delegates are requested to have their breakfast. And also the delegate cake, which is there. And
आप ऐसा करो इसको हट. keep this for KOH.
Hello, hello.
Hello, so we are having sound now, sometimes. Dr. Rajesh,
Yeah, hi Dr. Biplab.
yeah, just can you just explain that how you are starting an environment place?
So I am just, this is the first, I had packed superficially before patient was being draped, but you can see the synechia being formed there. All right, and you can see that this is a mass, right? Looks like a mass only as we expected. So I'll just make space, decongest first, and then we will proceed. Give me a scissor, endoscopic scissor, and a pack. So first of all, I'll break this synechia so that I have a good exposure. So that is the DNS spur. Can you see?
Yes, very clear.
Yes.
Nice.
Give me pack. Maxillary दो मुझे ये नहीं बेटे हाँ. So I'll take some time in nasal decongestion here because that will save our time later. All right, so it's a good practice to spend time at the initial decongestion. Section. थोड़ा सा local भी देना मुझे, okay? 1:2 lakh, yeah. 2 cc अगर possible है तो. Pack. Local. So I generally prefer to give small amount of local in the region of axilla. So because in my experience this actually reduces bleeding. Right, so many people have stopped using giving local. They say that there is no, but to me practically it makes a difference. Pack.
Yes, many of the people nowadays, they have given up, everything.
Yes. Back more. So on the left side also there are little secretions, but except for a small polyp which is an incidental finding, so there is no disease on the left side. So I think we do not need to go on the left side.
Correct. That is what we saw in the city.
Yes, that is what we saw in the CT, yes. So we have an adequate VP 126/76. So I'll like to reduce it a little more. The heart rate is 95.
I think we can request our anesthesia.
Yes, if otherwise we'll go ahead after that. So because in this case the approach will be a little different,
One more thing, Dr. Raji,
Yes.
our anesthesia friends, they have actually been supporting us for many days.
Yes.
Today, we actually shifted within a short period of time, shifted our time from 9 to 11. It's a big crowd across our anesthesia
Yes,
friends.
I am very thankful to them because they induced in no time.
Yes.
and the patient was ready in less than 10 minutes, right?
Big round of
So,
applause for our
thank you so much.
friends of anesthesia and our OT team, our nursing staffs and our OT assistants there who are working. Because of them only our this actually event is successful.
All right.
Meanwhile, I think the anesthetists which there are, my friend Dr. Pastor Mujumdar is there. Like if they want to brief the kind of anesthesia they are giving in this, they I think we can ask what their input. There is a comment from the Department of Anesthesia regarding the type of anesthesia they are giving for this. I think that will be also useful for the audience.
Dr. Viplab, see the secretions coming from here, right? So most likely they are coming from the frontal recess area here, the opacification that we saw on the CT scan. Now there is a little difference in approach when we are dealing with the tumor or when we are dealing with nasal polyposis. Yeah, so thank you so much. So now we have a very adequate favorable BP within no time. Give me a smaller suction. It's a number, देखना. Is it a number only? You can. Okay. So the difference mainly is that if you are dealing with a tumor and like there, it can be a vascular tumor, you have to be very quick in the nasal part of the tumor, because it gonna bleed a lot. Are you getting the point?
Yes, yes.
So when I am removing this part, all right, this part of the this tumor, I need to be quick. So I need to use bold instruments like scissor, lux, and I'll take out this, and it will be a little bloody, and then I'll see all my landmarks once I get the space to see. You see this, the tumor going till posteriorly. Huh? Okay. So our first is, if you have lux, give me lux. So in this case, first of all, my plan is I'll take a biopsy, then I'll remove all the nasal part, okay, which is coming in the nasal cavity. All right. So then I'll orient myself again, I'll identify the landmarks, then I'll go into the maxillary sinus and ethmoids and the frontal recess, because until I remove this part, I cannot approach. All right. So my first is to take a biopsy. So I am using lux forceps. See, so this is my lux forceps. So it's a friable mass. See, it's clean karna jaldi hai na. Yes. Yes. So I'll take a biopsy and then I'll quickly remove this mass from the nasal cavity. डिवाइडर भी अटैच कर लो. So this is definitely not an AFRS now, it is very clear, right? So yeah.
So that is actually a piece of information Dr. Rajiv is trying to give to all of us, that when we expect a case of like mass in the nasal bone, the first thing that we should do is take a biopsy.
Yes, take a biopsy.
Take a biopsy, send for histopathology.
Yes, divider now.
We sometimes forget to do, right? When we have divider in the hand, we can go and divide and remove the mass. At last, we don't have any tissue problem. So first thing that we have to do is that biopsy.
Yes. Foot switch. Suction ready, है ना? So we are just connecting the divider here. Is it ready? Suction नहीं चल रही. सक्शन फास्ट होनी चाहिए, सक्शन पूरी तेज. All right. So you see, I'll now my aim is to debride all this tissue as fast as possible. All right. So I'll take out all this tissue which is inside the nose. Block suction is not working. So we may need to do. We'll see. Suction fast चाहिए तभी ये करेगा. Okay.
सेक्शन चेंज करो सर सेक्शन लगा
सक्शन नहीं चल रही
सेक्शन डाले ना सेक्शन ना चेंज करो सर
give me a pack
काम कर रहा है क्या सेक्शन देखो
till that time give me a pack attach your best suction to the debrider. All right, pack. What? Pack. So you have got that ear suction tip. Yes, we'll give saline wash. All right, saline wash are the best things. We'll keep on giving saline wash. So I am just telling, what's your name? Huh? So Dr. Bagdatta, she is with me, and she will be using, saline washes. Give me saline now. So right, okay. So if I feel that I am having obstruction due to this spur, so maybe I'll remove this spur and then go ahead, okay? Is the debrider ready? So this is a 12-degree debrider blade that we are using. So it is almost, I think, equally good. We can do all those things that we do with a 0-degree blade here with this 12-degree blade also. So now this is in the maxillary sinus. So with this maybe I will be able to free, I'll leave the tumor in the maxillary and I will be able to free the nasal part. Let's see. अगर बात बता आपने ना सक्शन भी करनी है अगर बाय चांस ज़्यादा ब्लीडिंग होती है. So you have to put the suction and do the suction from the nasal cavity. Okay. You see superiorly, now can you see? Superiorly there is no disease here. It is all free. I think what we can do here is we can do this inferior turbinectomy because we have a tumor which is again medial lateral to the inferior turbinate also. Give me a turbinectomy scissor. This will make us give us space also.
Sir, would you like to, could you please explain the difference between anchors and modified anchors?
So, like these days we are all doing modified anchors. Whatever you see, it is modified anchor. In modified anchors, this is your piriform aperture. Okay, this you go from this, you give an incision here. You go lateral to this, open the maxillary sinus, remove all this bone, and you are head on with the disease. Suction, beta. I need a. Yes. Good morning. Block. हाँ. ये ट्यूमर है. ट्यूमर है. बहुत बढ़िया है. ये this will not work. बहुत बढ़िया. Okay. Yes.
What is anchors and what is modified?
So dankers is a little more aggressive approach. it removes all the anterior wall, and it gives a sublabial incision. And modified Danker is totally endoscopic. In modified Dankers, you just everything, there is no external scar or incision. In modified Danker, you just give a incision here at the piriform aperture. I'll show you modified Dankers in required, because this is bleeding. I'll just go ahead with this first. So it's a tumor, because it's a tumor, right? So this part of while I am removing the nasal part, it will bleed. All right. So once I am done with the nasal part, then I'll take care of this bleeding. So I told I need to be a little quick while removing this nasal part, because this is the bloody part, right? Give me a suction and a forceps, please. I don't think the patient has any previous biopsy report, because every time it was operated as an AFRS only. Lux. So this part is little bloody always. Moti suction.
मोटा सेक्शन दो ना
मोटा दे दो बायोप्सी. forceps दूसरी forceps. Hold the head. Suction. मोटी suction दे दो. Give me a bigger suction. Okay, see this part, last part coming out now. Give me lux again. See this nasal part now, right? So now we'll get a good space, and now we'll achieve the hemostasis also. Give me pack. You can see the nasopharynx, there is some tumor in the nasopharynx still. Give me pack now. So now we'll spend again some time in hemostasis. Then we'll go inside the maxillary sinus. 2-3 packs I'll need, okay? And the ethmoid, and see the origin of this tumor. Yes. So the bleeding will stop now, okay? So whenever there is a tumor in the nose, you need to be very, fast and aggressive, because to make space you have to remove this nasal part, and that will be a bloody surgery. So now we can remove this, the part of the spur also. Give me a knife if possible. I'll remove this spur. Yes, 15 knife. One more pack. Yeah, give me a smaller suction now. So can you please reduce the BP? The BP has increased. That's why it is bleeding a little more. BP and heart rate both are very high. थोड़ा मेंटेन कर दो बस बीपी को, ओके? एक और पैक दे दो तब तक. Yeah, very good morning.
Can you please, in the meantime, while you are meeting, can you please differentiate between endoscopy modified pre-lacrimal approach and endoscopic medial maxillary?
Pardon, endoscopic modified Dankers and endoscopic medial maxillectomy.
Yes, and pre-lacrimal.
So I exactly don't know what is endoscopic pre-lacrimal approach. So, but as the name suggests, you do endoscopic here. You remove the lacrimal bone and then you remove the disease from the maxillary sinus. Okay, so maybe in that way you may preserve the part of the inferior turbinate there.
Yes.
So can you, if you know, can you please answer this question?
Endoscopic modified Danker is a combination of endoscopic medial maxillectomy and removal of the part of the pyrethroid process and
Elevator.
pre-lacrimal approach is from the pyrethroid, just up to the pyrethroid or between the pyrethroid and the lacrimal bone. In this, you don't cut the lacrimal process or lacrimal tapes. You preserve the nasal lacrimal.
In pre-lacrimal.
Yeah, in pre-lacrimal.
Okay, so you means you don't come anterior to the lacrimal bone. That's what you mean?
Pre-lacrimal means anterior to the lacrimal bone or anterior to the nasolacrimal up to the pyrethroid.
Okay. So you maintain the lacrimal bone in between. You remove the bone anterior to it and you remove the bone posterior to it, right?
So posterior part, if you combine with the posterior part, then it becomes medial endoscopic medial maxillary.
Okay. So actually I am not very good with the terminology here. I am a little bit of simple surgeon, so I don't know these hi-fi terms, pre-lacrimal, and so I am just trying to remove the spur here. Elevator, just keep suctioning. Yeah, so that is a spur that is causing problems, so I'll try to remove this. So till that time maybe we have a normal hypotensive BP. Yeah, maybe suction elevator, yes. Yes. Yeah. Washes, yes, give me wash. Yes, washes are always helpful. So that is why I have packed a little and I am doing my septoplasty work, so that by that time I'll have a good BP and this bleeding will take care, okay? Wash, yeah. Yeah, that's all. Yes, elevator, suction elevator दे दो. Okay, so once I remove this part, and then I will have only the bony spur there, right? Suction करते रहो बेटे आप इसमें से आगे है ना, ये वाले पार्ट को सक्शन करते रहो. यस. सक्शन कर दो. यस, आगे इंटीरियरली. एंटीरियरली बेटे, यहाँ यहाँ यहाँ, यस, छोड़ दो, यस, सेक्शन कितना, यहाँ So I am raising the flap on the opposite side from the spur now. So this is a very anterior spur, right? So yes. So now give me chisel hammer.
For the interest of the audience, like when we come across like spars or bleeding at the spar area, how do you
What?
advise
Tap,
them to control the bleeding?
tap, 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 tap. Suction bhi kar. So like if you find a clear spotter, here you can use a bipolar cautery. All right, so you can use a lot of irrigation and then your suction elevator to keep your field clear. That's all. Chisel hammer now, right? I need to remove this spur. Yes, tap tap, tap tap. जोर से बेटे. Yes, done. बस हो गया. Suction. Yes, you see this spur? It's now free now. Okay. Give me clear suction. Yeah. हाँ, इसके आगे करो, यहाँ करो, छोड़ दो, दिखाना मत मुझे. So that's the spur. Okay, give me a suction elevator now. Now see how this was obstructing, and now see the space we got. Okay, so I'll pack a little. Give me a pack. बस थोड़ा बीपी कर दो अभी कम. सक्शन. Wash, sister, wash. Give me a wash here. That's all. ठीक है, thank you. See, so we have got a very good exposure now. So once the BP is controlled, I'll start again. Okay, give me pack. Give me debrider. Debrider straight, yes. Okay. So look at the exposure just by removing this spur we have. So before and now. So it will ease our instrumentation here, this part, okay. Yes, debrider. So now a little bit of posterior part is still left in the nasal cavity. So that is maybe the part of the middle turbinate that is left behind. So I'll just remove that. Suction काम नहीं कर रही बेटे अब इसकी debrider की. अभी ठीक है. So सक्शन 1 मिनट फ्लश कर दो और सक्शन दे दो. मोटी सक्शन लगाना. बस 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 ठीक है, थैंक यू. Okay, now are you getting the clear picture? So that is the residual tumor, that is my maxillary sinus, that is the posterior wall of my maxillary sinus. Alright, so now I'll remove all this tumor from the maxillary sinus, and if needed I'll remove this wall, this anteromedial wall of the maxillary sinus if the tumor is attached anteriorly. Debrider. इसकी सक्शन काम नहीं कर रही बेटा, ये ड्रिल ये ब्लॉक्ड है, ये कर ही नहीं रहा. अब कर रहा ठीक है. So I'll just keep on debriding this. Wash. Yes. Wash. Yes. So, are you oriented or not? Okay. Give me bipolar. I'll orient you again, right? So that is the axilla. Okay. So that is the cut end of the middle turbinate most likely. Can you see this? All right. This is a third revision case. Yes. Okay. And all this thing is maxillary sinus suction. This is a tumor. This was a very vascular tumor that was completely filling the nasal cavity. Okay, so we have removed the nasal part. We have quickly debrided it and taken biopsies. Alright, so the epicenter of this tumor is in the maxillary sinus. Alright, so see this attachment of the middle turbinate here, and that is the posterior wall of the maxilla. Is it clear now? And that is your infraorbital nerve I showed in the CT scan. Can you see? On the roof of the maxillary sinus. Okay? It was completely widened medial wall by the tumor. That is why even pre-operatively we suspected that this is not a case of simple polyposis or FRS, it's a case of some tumor mass in the nose. Alright, so it can be inverted papilloma. So looks like inverted papilloma to me. Yes. Lux. This is friable, yes. Alright, so this part, look. Yes. Pardon? What you? Look, to me I kept two DDs. One is inverted papilloma and another is hemangioparasitoma. Alright, so because even hemangioparasitoma on CT shows heterodensities like this has shown. It was not there, yes. Yes, but we don't had an MR. Had we an MR, our diagnosis would have been much, clear. Yes, so we have. We'll open. First of all, let me remove this part. Okay. So we have removed the nasal part. We have removed the posterior part from the maxillary sinus. Now we are left with the anterior part only. Okay. So I'll do some hemostasis here. Then I'll come to the anterior part. Give me pack. I'll just pack for some time. So I'll avoid using suction cautery, but I in my center use coagulator or bipolar cautery. Suction cautery causes more mucosal trauma. more burning and charring inside the, it is not a, it's a monopolar cautery with a broad suction tip. If it is a, very well defined bleeder, okay, you can use a monopolar cautery, like you can use this here if it is a big bleeder from the sphenopalatine artery and you don't have. But if this is a diffuse ooze, so I would not recommend anybody to use a monopolar cautery because it will char whole of the mucosa here. Give me one more pack and then I need a angled scope. हमारे पास कर्व्ड ब्लेड आ गया, कर्व्ड ब्लेड, डिवाइडर ब्लेड आ गया कि नहीं? Yes, so I need a 40 rad now and angled, we have a 45 degree scope and a 40 rad blade. Yeah, but the problem here is we don't have a this is an adenoid blade actually, we don't have a 45 rad blade. Give me a 45 degree scope.
45 degree scope.
इसको attach करना, I'll show them, okay? हाँ, ये attach करना, curved. I'll show them. So I'm using a curved sectional tip लगा दो, okay? I'm using a 45 rad and 45 endoscope now and a 40 rad blade. But the problem with that blade is that the cutting surface is posterior on that blade. So it's actually the adenoid blade. So now the cutting surface should be on the anterior surface, not on the posterior surface. You have backbiting? So that is with the 45 maximum, I can show you with the 45 there. So that is the tumor that is left anteriorly. So we are getting the divider blade. So that you see the issue is, so this is the blade I have got, you see, and the cutting surface of this 45 is posteriorly. So I cannot use to cut it anteriorly, alright. So I am left with only one blade here now, that is 15 degree. Give me वही लगा दो. Curved section. Give me some saline wash. Suction नहीं चल रही. Suction नहीं, suction पहले ये suction चलाओ. Suction नहीं चल रही, walk नहीं कर रही.
Suction एक तो भालो अनुस करे.
कर्व वो वाली वो खोल दो, कर्व ब्लेड.
कर्व लगा दे सर 45 डिग्री.
क्या सक्शन वॉश वॉश that's all. नहीं ये मत लगाओ यार, ये किसी काम का नहीं है ना. वही 15 ही लगाओ, ये इसका क्या कटिंग एज पीछे है, so this will not do any justice. Okay, 45 rad though, I'll do maximum with the 45 rad, whatever I can do. यार अब इसकी सक्शन नहीं चल रही, डिवाइडर की नहीं चल रही. So do something with the suction yaar. Okay, give me a probe. Give me a probe. Yes. Yeah. Yes, I'll do that. मुझे probe देना एक. So we are left with this anterior most part. Everything that probe नहीं है. ऐसे मत करो यार, कुछ तो दो. Yeah, so what I plan is, if I can remove this part a little, and I'll just anterior to the lacrimal bone and I'll try to remove this. But the issue is I don't have the curved instruments here.
So you use that cautery, cut this anterior, make an incision and do a modified anchors, go in and
You don't have a backbiting also?
actually you have to remove this part.
Yeah, I'll remove this part.
Use
Yes.
the cautery to make a cut there.
So I'll just use this. Maybe this will work here. No, it is also not cutting. You see?
Use the cautery to make a cut there.
It is not work properly.
It is not cutting.
It does not mean.
Yeah, I have removed it partially, you know. So if required, I'll remove it completely. So I'll remove it completely, then I'll make a opening along the inferiorly. Yeah. So give me pack. So there is no much bleeding as such now. Okay, give me 0 degree. Zero degree scope. No, divider nahi. 0 degree scope. Give me elevator. Elevator, please. Okay, so what I can do, because I don't have a curved instrument, so I need a direct access to this tumor then. All right? So I need an access, so I need to remove this part of the turbinate and this part of the floor. Give me a turbinectomy scissor. Mono, yeah, you can use mono by scissor.
It will be better if just cut monopolar.
Yeah, just wait. So I'll cut the inferior turbinate here. सक्शन करना इसमें. Yeah, give me forceps. So that can be nasolacrimal duct here, I am not sure, or it is behind this bone. Okay. Give me divider. Anyhow, we have to remove this this part. यार इसको चला दो ना, क्या हो रहा है, चल ही नहीं रहा डिवाइडर भाई. प्लीज चेक इट, है ना, उसको ब्लेड निकाल के उसको फ्लश करो. हमारे पास ये भी एक ही ब्लेड है, ये इसके दो हैं. इसकी स्पीड फुल है अभी डिवाइडर की.
स्पीड कितना है? 4000.
4000. नहीं, it goes till 4000 is very less. That is why it is getting blocked. नहीं, इसको बढ़ाओ, पूरा बढ़ाओ, ऐसे तो काटेगा ही नहीं. स्पीड देखो इसकी. नहीं यार, this will not work. See, काट ही नहीं रहा है. नहीं, even the rotation is very slow. The rotational speed is very slow. You see?
उससे ज़्यादा नहीं कर सकते.
No, it goes till 30,000 actually. Sir, I think the problem here is mainly the speed. That is why it is getting blocked again and again. See, it is not cutting. It is suction is working, but it's not cutting. Elevator. So what can I do now is either I can do a modified Denker then, and so that is most likely my nasolacrimal duct. Okay, so I'll cut it superiorly and then I'll remove this bone. Scissor. Okay, so we have to cut it superiorly and cut it sharp. Okay, that's all. Suction. Wash the wash. That's all. That's all. That's all. Okay, give me upturned forceps. Upturned forceps. So I'll try to take it out now. बड़ी सक्शन दे दो, स्ट्रेट मोटी. अब yes. Okay, so wash देना एक. Wait, let me remove this first, and I'll give me Lux. Okay, give me suction. Wash though. Wait. Nothing, no? Give me Lux. Okay, so this was the tumor that was lying in the anterior part. So I'll see, I think the some bit of the tumor is still left. Now give me a wash. Let us clear it for everyone to see. Wash please. Wait. Clean. Wash now. Yes. Wash. Yeah. Right. Okay. Give me scissor now. You see, I am flush with the nasal floor now. Okay, I'll just do. So you see, last bits of tumor are still there. So it is most likely arising from the floor. Okay, so I'll do a packing, give you a good picture, and then white balance, then maybe I'll come again. Give me a big gauze piece, okay, to pack. Give ribbon gauze to pack. Yes. Yeah, one more. Suction. Okay. डिब्राइडर का यार स्पीड देख लो अगर बढ़ता है तो, है ना? एक और दो. That's all. Okay, so I'll take 2 minutes for the hemostasis to happen here, and then we'll remove the final part of the tumor. The speed is good. पहले speed बहुत अच्छी थी इसकी, फिर कम होगी. अरे ये तो अभी इसको ऑसिलेटिंग मोड पे करो यार. Done? Okay, right, ठीक है. I'll see, right. Okay. All right, so let's see now. Give me suction and wash now, na, after this. Wash. थोड़ा आगे आके दो, है ना? Bring your suction. आगे आओ, हाँ. Yes. That's all. Very good, wonderful. Okay, so see this area that I was telling. So this whole of this area is raw. You see, I told you that this tumor went into the this pterygopalatine fossa on the right side. See, there is no wall, posterior maxillary wall here. Can you see? Hello, in the auditorium? Can you see there is no wall here? We are just anterior to the eustachian tube. And I showed you on the preoperative CT scan that this tumor was going, that this tumor was going into the pterygopalatine fossa here. Alright. So, give me a bipolar. I just bipolarize this area then. Have bipolar? So, that's the eustachian tube. Alright. And that is a pterygopalatine fossa. Alright. So, I cannot. Give me a bipolar. Yeah. So, I will just bipolarize this area that is causing bleeding. Suction karo, smoke. Smoke suck karo. Smoke, just place your suction there, yeah. Yes, press. Press. Yes, that's all. Suction on, suction, smoke suck karo na yaar. ऐसे करोगे. Press. 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 That's all right. No. It was only the tumor that guided us. Alright, so we didn't went to the pterygopalatine fossa intentionally. So, right, we just removed the tumor. Give me a debrider now. Yes, can you see that, no? So, I am just anterior to the eustachian tube and there is no bone here. See? Wash. Alright, so I still have a tumor there. Thoda wash dena, pulsatile mein. Yes. Suction.
Suction working.
Debrider again is not working. What's the problem? Saline दो. देखो इसकी suction काम भी कर रही है कि नहीं? So we are having a trouble with the debrider today. Curved suction देना बेटे.
Curved suction. Curved suction. Curved suction.
So that is the last part of the tumor that is left there. I am just teasing this mucosa with my suction tip. Upturned forceps. Take this biopsy.
Take a biopsy.
Give me suction. Not working. Please. Don't do this here. Suction is not working. Debrider is not working. Yeah. No, it's not bleeding much. The only thing is that the instrumentation is not working. There is some problem with the suction, I think. Yeah, so it can cause, it is causing, the suction is causing the problem even. That is why I think the debrider is not working. It is getting blocked again and again.
Sorry. Meanwhile, sorry. You can discuss a few approaches.
Give me
For such tumors there. Endoscopic approaches.
what? Give me this pack, yeah, big pack.
So if your tumor is going in the ITF, suppose,
Yes.
do you ever go with the pre-lacrimal approach or maybe
So if it is going in the ITF, I would go straight away with modified Denkers. All right. So no pre-lacrimal approach for me doesn't exist. Yes.
so it's a fancy approach?
It's a fancy approach. For me, either endoscopic or modified Denkers. That's all.
There is a spurter from the Spur pattern.
Yes, from the artery here. So I try to, I can bipolarize it maybe. So I need to make sure first that I have removed the whole of the tumor here from here, right? Give me a pack. Curved suction लो बेटे.
That one is 2 weeks. Third one.
I need a curved one because
Third one.
so I feel there is still some residual tumor there, maybe in bits. No curved suction नहीं है? No. We have already removed the tumor from the pterygopalatine fossa. Wait, wash से कुछ नहीं होगा. Suction block करना है, 1 मिनट. Block the suction from here. Suction को block करो एक बार. हाँ block करता हूँ ना. अभी छोड़ दो. देखो डिवाइडर वर्क किया कि नहीं किया.
वही है 5000 मैक्सिमम ऑसिलेटिंग मोड पे. ऑसिलेटिंग मोड 5000 मैक्सिमम.
হ্যাঁ এটা তো লুজ হয়ে গেছে এটা নতুন না জানাচ্ছি এটা কি অবস্থা
हाँ. Now give me divider. Yes. Yes. So I think this was the where the tumor was arising. Can you see this attachment here? You see how it is getting the vascularity from here. All right. Yeah. So that is where it was getting its attachment. So that is from the posterior wall. Maybe it's a branch of the. Yes, it's a spurter now. Yeah. So give me a bipolar. So now I am sure that I have removed the tumor. So this bleeding is not a problem for me. You see, it will stop. It will stop even with this, with the packing only. Yes, suction. So okay, I'll pack a little then I'll do it. Pack though, pack. So but this bleeding makes sure that we have removed the tumor, because there is no vessel as such which arises from the posterior. This is all bone, you know. There is no vessel as such which supplies the mucosa. So this was the main branch that was supplying the tumor. Give me pack. Boss, maybe I'll use the bipolar after packing a little. Yes, I'll just pack and then maybe I'll use unipolar here. because bipolar won't work. There is no space for the two prongs to hold that bleeder.
Section.
You have a monopolar?
Yes, sir. Prepare.
Monopolar, put small suction tip like this over here. All right, and then we'll monopolarize. Give me suction. नहीं दूसरी बड़ी सेक्शन पहले फिर छोटी. All right, give me a monopolar now, right?
लगा दो सेक्शन पे.
हाँ, छोटी सेक्शन. Yes, touch now. Please touch.
सर सेप्टम में टच हो रहा है. सेप्टम जल जाएगा ना सर.
Wait. Now.
नहीं लग रहा है.
Now.
टच हो रहा है.
Now. इस पे कुछ लगा दो ना सेप्टम पे.
गोस्पिस लगा सकते हो.
हाँ अब करो चलो. टच. Touch, yeah. It's not doing. Give me this. Yes, that's what I'll do. Can you put the suction inside now? Put the suction inside, yeah. Suction, keep the suction in the floor. All right, press now. Press. The moti suction. Wash. Yeah, it has stopped now. So I'll have a look with the angled scope maybe. So I think I'm done, but I'll like to have a look anteriorly. So, yes, we can induce the second case. Yeah. So looks pretty clear to me now. All right. All right. So.
Wash and scrape with the gauze and then pack it.
Yeah, so I don't think so. We need to scrape it, and we are removed. I'll not like to traumatize the mucosa. Okay. All right. Thank you so much.
Thank you. Good job. Clapping.
0 degree and final pack.
And we should get the second patient ready, please. earliest. So that you know, we save the time.
Suction.
Sir,
Elevator. Elevator.
Second case, let somebody take
Elevator. Elevator.
and Sambhata, let them start the second case preparation. Okay, to save the time.
Patli suction. Patli suction. Final pack, okay?
sir, ready.
Give me bipolar. I need to bipolarize this also. Bipolar. Press. Press, yeah. Okay, that's all. Suction. कोई बात नहीं. पैक बड़ा सा रिबन गॉज पैक चाहिए इन सोफ्रामाइसिन, ओके? ए फुल बैंडेज, यस.
1 meter long.
या
अभी थोड़ा पैक चाहिए सिस्टम.
suction. No. That's the